Hello everyone, it's Dr. Locklear here, and I'm coming to you with Module 13, Mobility, and we're looking at Exemplar 13F, Parkinson's disease. And this is a very unique disease. A lot of times these patients don't really have anything else wrong with them except the Parkinson's, and so it's almost a disease of being trapped within your own body, just like Alzheimer's. So let's get started. So what are our outcomes, learning outcomes for this lecture and this information? We want to describe the pathophysiology of Parkinson's disease, or PD. So what causes it? How does someone get Parkinson's? When we think of Parkinson's, we often think it's a disease of older adults, but if you all are familiar with the actor Michael J. Fox, he was diagnosed in his late 30s, which was very rare for someone with PD. And his situation has evolved over time, and now he's in his early 60s still dealing with major effects from it. So it is a very long, drawn out type disease. People can live a long time with it. What is the etiology? What causes the Parkinson's to occur? And we're going to talk about something called dopamine and Lewy bodies and acetylcholine and things like that all play a role in this disease. What are the risk factors? What puts someone at risk for developing Parkinson's, and how can we prevent it if it can even be prevented? There is no cure for Parkinson's disease. What does the clinical manifestations look like? How does a person look? In my lecture on MS, I talked about something called affect, which is the expression on your face. And you will see with these patients, they have what we call a flat affect because their muscles are so debilitated, they can't make facial expressions, so their face always looks flat. What are the diagnostic tests? What do we look at when we're trying to diagnose and treat people with PD? And what does the collaboration look like? Shuffled gait. You're looking for that kind of bent over posture, those type of things. It's a disease that really affects movement for folks. So what is our overview? Parkinson's disease is a progressive neurologic disorder. It affects your movement. It was described in 1817 by James Parkinson. He was a British physician, and he called it the shaking palsy because you do have shaking, you have tremors in your hands, and you have uncontrollable movements at times. It's usually characterized by unilateral hand tremor, but it progresses to bilateral. So sometimes it starts in one hand and then it'll move to the other hand. It progresses slowly, and you may see rigidity. So the patient looks stiff. That's what it means. Their muscles are rigid. And bradykinesia. Now we know from our EKG lecture that brady means slow. So bradykinesia means slow movements. They are very slow in moving, and they have a shuffle gait. They can't pick up their feet, so they shuffle their feet. And their posture is kind of a bent over posture. They can't stand up straight, which makes them at risk for falls. These symptoms degrade unable to care for themselves and very totally dependent. They lose their independence. So what is the patho? Dopamine is a brain neurotransmitter. It regulates our movement, our voluntary movement. So it's that movement that we make ourselves do. reward-seeking behavior, memory, and learning. It affects a lot of things. The dopamine receptors are expressed throughout the brain, including the substantia nigra pars compacta. The loss of dopaminergic neurons in this area and decrease of striatal dopamine are characterized by the Parkinson's disease. So now we know that a decrease in dopamine is what leads to the Parkinson's type movements and disease process. Parkinson's is also characterized by the presence of what we call Lewy bodies in the neurons. They are abnormal aggregates of proteins, including alpha-synuclein. The purpose of Lewy bodies, including whether they are helpful or harmful, is still under investigation. Loss of dopaminergic neurons that connect the substantia nigra to the cholinergic neurons in the corpus striatum results in abnormal nerve firing patterns that cause impaired movement. That was a whole lot to say. When our dopamine levels are inadequate, then we have issues with the firing of our neurons, which affects our movement. So when dopamine neurons degenerate, acetylcholine signaling increases, and it causes an imbalance of dopamine and acetylcholine. And so when dopamine neurons are degenerated, acetylcholine signaling is increased. It causes an imbalance that contributes to the manifestations of Parkinson's. Dopamine and acetylcholine must be balanced to produce smooth movement. So when there's a degeneration of dopamine, acetylcholine takes over, and now there's too much, so you don't have that balance. So dopamine and acetylcholine. So what is the cause? The exact cause is unknown. Many researchers believe it comes from a combination of genetics, susceptibility, and exposure to environmental factors such as toxins, and it may be hereditary. Most cases of PD are sporadic, which means the disease occurs randomly with no definitive genetic link. So it can just kind of come out of nowhere. So what are the risk factors? Age is the primary risk factor. The average onset is 60 years old. The risk increases with advancing age. Men also have a higher risk, 50% more than women. Studies indicate that individuals who live in rural areas or work in certain professions are at higher risk, providing an environmental link for Parkinson's. It can also be a genetic mutation. Individuals with early onset or juvenile Parkinson's are more likely to have a genetic mutation than late onset. So just like the actor Michael J. Fox, he was diagnosed at age 38, so possibly a genetic link there for him. Prevention. Because the cause of Parkinson's is unknown, there's no definitive way to prevent the development of the disease. So once it starts, all we can do is treat the symptoms to make the patient as mobile as long as possible, independent as long as possible, safe, because it does debilitate them and eventually they become total care. However, several prevention techniques have been suggested by experts, including consuming a healthy diet high in fruits and vegetables, avoiding herbicides and pesticides because these are poisons, consuming moderate amounts of caffeine and green tea. So some of us who are living on caffeine right now, we ought to live a long time and hopefully not get Parkinson's if that's the case, because I have, not about you, but I have to have my coffee every day. Consumption of nutritional supplements including vitamin C, D, E, coenzyme Q10, creatinine, and steel beans may also help prevent PD. Diets high in flavonoid-rich foods. It include berries, red wine, tea, and eggplant. And so, diet may play an important role, but again, we just don't really know. These are just factors. Clinical manifestations. The clinical manifestations can be divided into motor and non-motor symptoms. Motor symptoms include the 4 classic symptoms of PD. So there's 4 specific things we need to look at. Tremors in the hand, one or both hands, unilateral or bilateral. Rigidity, so you have a stiff movement. Bradykinesia, slow movement. And postural instability, the inability to stand up straight. Non-motor are cognitive deficits, emotional changes, and sleep problems. And so these patients eventually do have difficulty with cognition, remembering, and saying the right things, sometimes knowing the right words to say. What are the motor symptoms? So motor symptoms that are associated usually begin unilaterally. As the disease progresses, the patient will start to see bilateral effects, but the side affected initially will continue to display more prominent deficits in motor function. 2 of the 3 symptoms of tremor, rigidity, and bradykinesia are required for the Parkinson diagnosis. So you have to have 2 of these 3. Postural instability generally develops later on in the disease as the muscles become more stiff. Tremor or trembling of one hand is an early sign, but now it can, a little twitch in your hand can be indicative of other things. You could have a spinal cord injury. You could have thyroid disease. So a thorough physical exam is necessary. And the tremor will get worse. It won't go away. Tremor is most prominent when the individual is at rest, and it generally abates with movement. So tremor may be accompanied by pill rolling. This is where you take your thumb and fingers and rub them against each other constantly, just nonstop. Trembling of both hands, the arms, legs, jaw, and face often occur as the disease starts to progress. Trembling interferes with activities of daily living because they're trembling so they can't hold the fort to feed themselves or put their clothes on or walk safely. It really does debilitate the disease. Tremor can be exacerbated by stress or excitement. So if they get stressed or excited, the tremor gets worse. It is generally the symptom that causes the individual to seek help. Why is my hand shaking? I can't get my hand to stop shaking. Even when I'm sitting down, my hand won't just quit moving. And they may feel a little stiff, difficulty doing activities of daily living. So they'll seek out, a healthcare provider and say, hey, these are my symptoms. Rigidity or resistance to movement occurs because of the involuntary contraction of the skeletal muscles. Muscles remain contracted when they should relax. That's what causes the stiffness. It upsets the balance of the opposing muscles and it prevents movement because they're kind of stiff. This may lead to muscle aches and weakness, so they may have to take some type of ibuprofen or something to help with the pain. Muscle stiffness of the trunk and limbs can limit range of motion and cause pain, and muscle rigidity of the trunk also can limit your ability to breathe properly, which affects our airflow, which can lead to lung collapse. Rigidity is most obvious when another individual tries to move the patient's arm, which will move only in short, jerking movements known as cogwheel rigidity. So these are the short jerking movements that you may see. Bradykinesia or slow movement. This affects the voluntary and the automatic movements. Bradykinesia of voluntary movements causes the performance of ADLs, such as our bathing and dressing and feeding ourselves and grooming. It takes a longer period of time and the patient gets frustrated. You have to have a lot of patience with Parkinson's patients. This can lead to frustration, and then the patient can lash out and they can be difficult to take care of. Steps may become shorter with walking, and the arms may not swing automatically. And we need to kind of swing our arms a little bit when we walk to help balance us. They also have decreased blinking, which can cause dry eye as well. Another effect of bradykinesia is difficulty with speech, swallowing, and chewing. So their diet's affected, they lose weight, they look very malnourished, and they have a high probability of aspiration, and which causes aspiration pneumonia. And aspiration is when you get food in your lungs. This manifests itself in excessive drooling because they're not able to swallow constantly. We're constantly swallowing, we don't even realize it. Difficulty eating, so their diet can be affected. Usually these patients look very emaciated and underweight. Slurred speech, lengthy pauses during speech because they don't have the muscle movement to move their tongue, and they're having some cognitive delay as well. And a lower voice volume, which is hypophonia. So they may speak very soft, and you may not be able to hear what they're saying. Postural instability is characterized by this stooped posture, and this leads to issues with balance, and so they're at risk for falls. And because of the shuffle gait, they often trip over their own feet as well. It leads to retropulsion, or the tendency to topple backwards when bumped or when rising, standing, or turning. So in other words, you can knock them over real easy. So they're very prone for injuries. A Parkinsonian gait is characterized by small shuffling steps. The steps may be characterized by bradykinesia or slow movement, or they may be rapid as if the individual is trying to run, festination. But now it's a very fast shuffle gait. Okay, they're not picking their feet up and moving fast. It's a fast shuffle. They're still shuffling their feet. When walking, the whole foot generally strikes the ground simultaneously, or the toes strike first, which differs from the normal gait of the heel striking first. So when their toes are striking first, it can put them off balance. Individuals may also experience freezing, in which it feels as though their feet are stuck to the floor. And of course, this causes a risk for falling and injuries as well. Non-motor symptoms, these include fatigue, irritability, and loss and sense of smell. So, we see that with COVID right now, loss and sense of smell. So you got to remember, 2 of the 3 symptoms, okay? I underlined that in my book. Other non-motor symptoms, dementia. They start having issues with their cognition. This is usually later in the disease. Cognitive defects usually begin with slow thinking. They just can't put it together. They can't quite remember. They also develop confusion and memory loss, which causes a lot of irritability and anxiety and fear. They can have Parkinson's dementia, which is very similar to Alzheimer's, but it is completely different. Emotional changes, depression, anxiety, fear, and panic, which makes it difficult to take care of them. They can have issues with sleeping. They can stay up all night, and then they're very fatigued in the daytime because they're tired. They haven't had any rest. They can have insomnia, daytime sleep attacks, restless leg syndrome, parasomnias, and REM sleep behavior disorders, frequently awakening during the night. So what is all that, Dr. Locklear? It just means they're not sleeping good at night. They may just suddenly fall asleep in the daytime sleep attacks. They just fall asleep like that. And then they only sleep for a few minutes. And it makes it difficult to take care of them because they become very agitated during this time. Parkinsonism, this is a combination of motor symptoms, usually seen in Parkinson's disease, and you see a combination of motor symptoms. Not everyone who has Parkinsonism has Parkinson's disease. Parkinsonism can result from medication, head trauma, and other neurodegenerative disorders. Patients with tremor, bradykinesia, and rigidity that do not respond to dopaminergic drugs are usually classified as having Parkinsonism rather than Parkinson's disease. So it's not the true disease, it's disease symptoms that look like Parkinson's, but it's caused from other issues, not the dopamine and acetylcholine. Collaboration, there's no cure for Parkinson's. It's treated by a team of neurologists, primary care providers. You want to control the symptoms. That's what some of the medicines do. And just make sure that they're safe, that they're getting their nutrition. A lot of these patients end up with a feeding tube. Our nursing care should focus on support for the caregiver because this disease will progress. So the caregivers need a lot of help as well. Diagnostic test, the FDA approved an imaging technique called the DAT scan for patients with symptoms of Parkinson's. The DAT scan involves the injection of a radioactive ioflupane I-123, which binds to the dopamine transporters, the DAT, in the brain. This allows visualization of dopaminergic neurons using single photon emission computed tomography scan or SPECT. Patients with degeneration of dopamine neurons will show less uptake of ioflupane I-123, which can be evaluated by a trained neurologist. So this is a very detailed test, and they actually can see if they're not taking in enough dopamine. Patients should drink plenty of water the day of the test and 2 days after to promote excretion of the iodine. After the injection, the DAT agent takes about 3 to 6 hours to distribute throughout the body. The scan, once started, takes 30 to 45 minutes, which can be a lifetime for someone that has Parkinson's to stay still that long. Surgery. Deep brain stimulation, or DBS, is a procedure in which a neurostimulator is implanted into the individual to send electrical signals to 1 or 3 brain regions: the subthalamic nucleus, the globulus pallidus, or the thalamus. The subthalamic nucleus is the most common target, and they get the best results in this area. Stimulation of the globulus or the subthalamic nucleus reduces tremor, bradykinesia, and rigidity, whereas stimulation of the thalamus primarily reduces tremor. The DBS consists of 3 parts: the lead or electrode, which is placed in the brain, the neurostimulator, which is usually placed near the collarbone, and a thin insulated wire which connects the stimulator and the lead. DBS often allows patients to decrease their dosage of levodopa, which is one of the medicines of choice, and we're going to look at that on page 957, which can decrease side effects such as dyskinesias. Dyskinesias are those things like the pill rolling I was talking about. Complications of DBS include hemorrhage, infection, misplacement or dislodging of the leads, component failure, and stimulation-related adverse effects. And so there's, just a few things that they can do, but again, it cannot be treated. Look on page 957, clinical manifestations, and it shows the lower limb and trunk, upper limb, head and neck, cognitive, emotional, sleep, bowel and bladder, and others. Orthostatic hypotension, so we've got to take their blood pressure. And under clinical therapies, levodopa is one of the drugs of choice. It's been around a good little while. You will see some other medications, but levodopa specifically treats the dopamine issue with Parkinson's. So our pharmacologic therapies, no pharmacologic cure is available, but there are many medications effective at reducing the severity of the symptoms. The goals of pharmacologic treatment for patients with PD are to improve the quality of life, reduce disability, and maintain their ability to work or just function. So we've got levodopa and dopamine agonists. So levodopa you see the symptoms of PD result from a lack of dopamine in the brain. The best way to treat PD is to increase the dopamine levels. The primary drug used for this purpose is levodopa. It is the mainstay. It is the treatment of choice. It is effective at reducing tremor, bradykinesia, rigidity, but problems with balance and non-motor symptoms may not be relieved. It is a natural chemical that can cross the blood-brain barrier and be converted directly to dopamine in the brain. Levodopa can also be converted to dopamine outside the brain, which leads to the most common side effects of nausea and orthostatic hypotension. So, with that being said, levodopa has to have some help. So we add the drug carbidopa. And so this prevents the levodopa from converting to dopamine until it reaches the brain. So it helps control these side effects such as orthostatic hypotension and nausea. As the patient continues to take levodopa, its effectiveness diminishes. This causes the patient to experience an on-off-again effect characterized by sudden lack of symptom control and unexpected dyskinesias. With increasing doses and long-term exposure, levodopa usually causes dyskinesia, which may become less tolerable for the patient than the symptoms. And the dyskinesias are those things, like I was saying, the pill rolling, smacking your lips, constantly moving your tongue. You can't stop it. It's just a side effect of these medications. And a lot of times when they take patients off, there's lots of medications that cause dyskinesias. When they take them off the medicines, the symptoms still continue because the damage is done. But with someone with Parkinson's, you don't want to take them off the levodopa. Safety alert. Although the FDA requires generic drugs to show an essential similarity to the correlating brand name drug, generic substitutions may have different levels of efficacy and side effects in comparison to brand name counterparts. The patient should be cautioned to consult the primary care provider before switching to a generic drug. The patient should also report any differences in effectiveness and the side effects after switching. So you want to make sure that you're taking what the brand name for the levodopa. Now we've got our dopamine agonist. So what do these do? Dopamine agonists are not converted directly to dopamine. Instead, they act similarly to dopamine in the brain by activating dopamine receptors. So they activate these receptors to use the dopamine. Dopamine agonists are not as effective as levodopa, so they are often used alone early in the course of the disease when the symptoms are minor. Dopamine agonists have a longer duration of action compared to levodopa, so they may also be used later in the disease with levodopa to prevent the on and off again effect. So as the disease progresses, you may see a patient that's taking both of these medications. In addition to the side effects seen with levodopa, dopamine agonists may also produce hallucinations, swelling, drowsiness, and compulsive behavior such as gambling and overeating. Isn't that amazing that these medicines can make you have those thoughts? Dopamine modifiers, these are used to extend the action of dopamine in the brain. They include your MAO-B, which are these are your monoamine oxidase B inhibitors, and your catechol-O-methyltransferase inhibitors, or your COMT. When given with levodopa, the MAOs inhibitors can enhance and prolong the response to levodopa and reduce wearing off effects. So it helps the medicine work longer. The COMT inhibitors reduce the breakdown of levodopa to an inactive intermediate product, thus increasing the availability of levodopa in the brain. When taken with levodopa, COMT inhibitors can decrease the duration of off periods and reduce the required dose of levodopa. So this helps keep the levodopa in the brain so you don't have to take as much of it, which is a good thing, because we know when we're taking medicines, the more we take, the more our body gets used to it and becomes immune, and it takes more medicine to get the effect. Other medications, anticholinergics were the first class of drugs used to treat PD. They reduce tremor and rigidity by decreasing acetylcholine and restoring the balance of acetylcholine and dopamine in the brain. Because of side effects in older adults and limited usefulness for most Parkinson patients, anticholinergics are only prescribed to younger patients whose primary symptom is the tremor. So they're not the best drugs for the older patient. Amantadine is an antiviral medication. It provides short-term relief of mild symptoms. It may also be used in addition to levodopa to help control dyskinesia for these patients in the later stages. Drugs for non-motor symptoms. Classic medications for PD do not treat these symptoms, so additional medications are prescribed, such as amitriptyline for depression, fluoxetine, anti-anxieties, benzodiazepines, or your atypical antipsychotics. The antipsychotics, quetiapine and clozapine, may be prescribed at bedtime to reduce frightening dreams or to treat psychosis. Patients on clozapine should have their blood monitored frequently for agranulocytosis, because this can affect red blood cells and white blood cells. Olanzapine and risperidone may be given to treat hallucinations, but like traditional antipsychotics, they may worsen the PD symptoms, and you see a lot of dyskinesias with risperidone as well. Orthostatic hypotension may be treated with fludroconazole, and sildenafil may be used to treat erectile dysfunction. Oxybutynin is often prescribed for patients with bladder dysfunction because it helps with the spasms, and seborrheic dermatitis can be treated with ketoconazole. Rivastigmine can be used to treat dementia. So as you see on page 959, here are your drugs. And so levodopa, and then the combination of levodopa carbidopa, and you be careful with some of these. I highlighted some specific things. A high protein diet may interfere with levodopa absorption. So patients should avoid protein rich meals when taking levodopa. So what are meats and things like that are high in protein? Do not take vitamin products containing B6 because it can counteract it. Some of these medicines cause absorption issues of the medicine. The drug should be cautiously used in patients with heart, kidney, liver, or endocrine disease. It can interfere with several lab tests and other drugs, so you have to be monitored for interactions. Your dopamine agonists, they have some nursing considerations too. These drugs cause compulsive behaviors, and they list some of those there for you. And then there's segoglin, razaglin, and these are your MAOs, and then your COMT inhibitors that we talked about. Other ones, your anticholinergics, and then your amantadine as well. Non-pharmacologic. So non-pharmacologic therapies are used as an adjunct to help patients prolong the early mild stage of the disease. Exercise is the most important non-pharmacologic therapy for patients because it gets them going. Okay, things like Tai Chi, yoga. It talks about something called Alexander techniques that help with movement and mobility, muscle strength, and of course PT, OT, and speech as well. Nursing process. It begins before the age of 50, early onset. So when you're looking at the lifespan considerations, you want to look, is this person less than 50? What could be causing this? And again, anybody with can get Parkinson's. I got Alzheimer's on my mind. They are more likely to have dystonia at onset and dyskinesias, involuntary movements such as a tic, and the tic is what I was telling you, like their facial twitch. They can't stop their tongue from moving. That's a tic. in response to levodopa treatment. Early onset Parkinson's is often inherited. Women should be made aware that the effect of Parkinson's medication on the efficacy of birth control is not known. So if you're younger and you're getting it, you may not know. So what's our nursing process? Nurses play a key role in performing patient assessments for changes in symptoms, effectiveness of medications, and new patient concerns. So what do? We document, document, document. If it's not documented, it's not done. So what's our observation? We want to look at the patient, look at their affect. What is their facial expression saying? Usually they have what we call a mask-like face because their face stays the same. It doesn't show any expression. It's kind of fixed because they can't move it. You want to look at their gait, their movements, their tremors, their ability to carry out their ADLs, what is their health history. Let them describe the symptoms for you. Any issues with, just being able to dress themselves and feed themselves, and any other non-motor symptoms such as cognitive status. And you can tell when you're talking with someone if they have cognitive issues. The physical exam often follows the Unified Parkinson's Disease Rating Scale, which rates patients in 42 different areas in the categories of mentation, behavior and mood, ADLs, motor examination, and complications of therapy. The mentation, behavior, and mood assessment includes intellectual impairment, thought disorder, depression, and motivation. The ADL, of course, looks at speech, swallowing, handwriting, hygiene, walking, tremors, and other things like ability to feed and dress yourself. The motor, facial expressions, tremors, finger taps, hand movements, rapid alternating movement of hands, leg agility, ability to rise from a chair, posture, gait, bradykinesia, and others. So the movement portion of this is looking at all aspects of your body parts that should move. Complications included in the assessment are dyskinesias, on and off again periods, sleep disturbances, and others. And then there's the modified Hone and Yar staging scale and Schwab and England activities of daily living scale as part of this review process. Here are your diagnoses. One of the biggest ones is mobility impaired, risk for falls, self-care deficits, constipation, impaired memory. These are all very, very important. High risk for falls. Your goals, several bullets listed here for you, and you can read these for yourself, but your goals should be opposite of your nursing diagnoses. So free from falls, being able to, feed yourself half of your meal, participate in the therapies, maintain your weight, hopefully decrease symptoms, okay? Implementation. So what do? We want to prevent injury. We need to make sure that the patient is getting up with help. They have on good fitting shoes. They're using their devices such as a lift chair, raised toilet seat, walker, cane, whatever will help balance themselves. Free of clutter, remove the rugs, remove the floor hazards. Don't let them walk around in socks because they will definitely fall on the floor. Encourage patient to walk daily. Range of motion, and this range of motion may be passive range of motion instead of active. If they can get on a treadmill, if you can get them to a fitness center or somewhere like that, and provide encouragement, tell them they're doing a good job, promote independence, let them feed themselves, let them use their assisted devices regardless of how long it takes, let them bathe as much of themselves as they can and dress themselves as much as they can. And, as a caregiver, which we shouldn't do this anyway, don't complain when you're caring for these patients, and you shouldn't do that anyway. On page 963, you have strategies to minimize symptoms and complications of PD. So here's some strategies, and I want you to read over these. Take your medications on time, because these medicines have to maintain a therapeutic level within your system. Consume a balanced diet. decrease protein, drink plenty of fluids, keep yourself hydrated, but avoid dehydrating foods such as coffees and teas because we know those are natural diuretics, so you'll go to the bathroom a lot. Use proper walking techniques. Place the heel of your foot on the floor, not the toe. Look ahead. Try to get them to hold their head up best they can. Maintain a strong voice by taking a deep breath. Reduce throat clearing and coughing. Rest the voice when it's tired. No smoking. Cut back on caffeine and alcohol. Allow time for ADLs. Do not rush them. It agitates them. You've got to have patience with these type of clients. If bladder is a problem, they need to be on a bathroom schedule. You need to take them to the bathroom every 2 hours, if not more often. Give them a good bath before they go to bed. Maybe that'll help them sleep. To maintain balance, don't pivot the body. Don't let them lean too much. You may have to walk beside of them and to help them balance, okay? And then on page 963, there is a safety alert. Individuals with PD who have difficulty swallowing may aspirate foods that have a thin consistency, such as juice or broth. Products to thicken liquids to prevent aspiration should be used, and this is called thicket. You will get this through dietary, so the dietitian needs to be consulted. You do have to have a doctor's order for thicket. And the nurses stress the need for adequate hydration. Offer fluids every 2 hours. Aspiration can lead to life-threatening complications such as pneumonia. And then on page 964, it talks about using reachers and grippers and things that they can use to reach things and not have to continually reach over or get up for it and possibly fall. Evaluation, we want to make sure that they're safe. We want to make sure that they got the education that they needed, that they're adhering to their pharmacy protocol, that we're addressing their emotional status, that they are maintaining safety, and that they're maintaining their independence as much as possible. Please review the care plan on page 964. And this is talking about a patient with Parkinson's. It gives you your little assessment, the diagnoses, and the planning and the implementation for that.